gynecologic cancers. He performs brachytherapy for prostate and gynecologic cancers. He also engages in career research and teaching. Dr. Alexander.
Thanks. Thanks for having me back. I think it was about 2 years since I was here last time. So I'm going to talk to you today about the evolving or changing landscape of radiation treatments for prostate cancer. And what I was hoping to focus on is to talk to you a little bit about some of the recent changes that have come about in the way that we apply radiation treatments to prostate cancer. And I don't so much mean changes in technology, because that happens with time, but sort of changes in how we look at the disease, how we deliver our treatments, and what situations we deliver our treatments for. I mean, there's situations that come up now that we deliver radiation treatments for that we didn't used to use radiation treatments for, and there's ways that we give radiation now that we didn't used to as well. So here's the things I'm going to talk about. I'm breaking it up sort of into two halves. The first half of the talk, I'll be talking about some of the newer changes to radiation treatments in the management of cancer, prostate cancer that are localized, so localized being cancers that haven't spread and are potentially curable. And then the second half, I'll talk about some changes to radiation for prostate cancer in the setting of someone who has metastatic disease or cancer that has spread. And I just figured I'd pick sort of three examples in each category to chat about. It might be a little bit much, in which case I'll just skip over a bit of it. So first of all, I was going to talk about localized disease. So again, as I mentioned, this is prostate cancer that hasn't spread. And I was going to talk, the first example of a change that's come about in the past 2 years in how we treat prostate cancer is with radiation treatment is in the duration of the treatment. And I guess I should just step back for a second and just mention just review really quickly what the treatment options for men who have localized or potentially curable disease are. Men who have localized prostate cancer can do, there's basically 4 different standard options. One is to wash the disease, which may be appropriate for some men. The other option would be radical prostatectomy, which is having the prostate gland removed. There's prostate brachytherapy, which is where we implant radioactive seeds or radioactive materials into the prostate gland. And then the last option is what we call radical external beam radiation treatment. And that's where we essentially zap the prostate gland from the outside using an external radiation machine. And these are sort of the 4 options that are available to all men. And which one of these options is right for a particular man depends on how risky their particular cancer is, how old they are, what other health conditions they have, life expectancy, and what side effects they're willing to risk. The most of what I'm going to talk about today is to do with the last option, the external beam radiation treatment for the most part. And so the first thing I was going to talk about is a concept. It's called Hypo Fractionation. And all that means is delivering external radiation treatments with a smaller number of treatments or fractions. And what I mean by that is most of you who have been either had external radiation treatments or been offered external radiation treatments have probably heard that unfortunately when we give external radiation treatments for prostate cancer, it tends to be a long haul. These days, the courses of treatment don't involve just sort of one radiation treatment. Men, unfortunately, have to come back, one day after another, usually Monday to Friday, for many weeks of treatment. And in recent years, the courses of treatment have been as long as 37 treatments to in south of the border up to 44 treatments. And so that works out to about 7.5 or 9 weeks of treatment for each man who has to go through. Who chooses to go through external beam radiation treatments for their prostate cancer. And if anyone's ever wondered why, this is just, I thought I'd explain why, because people often ask me, why are radiation treatments, external radiation treatments so long? Why do people have to come back for so many treatments? Why can't we do it in a shorter number of treatments, 1 treatment or 5 treatments? And this little graph sort of explains why. And what this is a graph showing the effect that radiation has on tumor cells and normal cells if we give a single shot of radiation. So basically this is a graph of dose going up this way, radiation dose, and how many cells are surviving that dose. And these 2 different curves, one curve is for how tumor cells respond to doses of radiation. The second is how normal cells in the body respond to radiation. So if I give somebody, say, a big dose of radiation by this blue line, if I give a large single dose of radiation, if you look at it, I'm actually killing more normal cells than I am tumor cells, which is bad practice. We don't want to do that. But if we give a really small dose of radiation, by the green line here, I'm actually killing more tumor cells than I am normal cells. Not by a whole lot, but I am getting a bit of an edge there on killing the tumor cells over the normal cells. So that's what we take advantage of with external radiation treatment. We choose a small dose of radiation to take advantage of that little differential you see there between the number of normal cells we're killing and the number of tumor cells we're killing. So the principle then is to just keep giving a bunch of small doses of radiation, and each time we kill more tumor cells than we do damage the normal cells. And then because that is then additive, at the end of the day, by giving, because each small dose or fraction kills more tumor cells than normal cells, if we give a series of small doses once per day, then that effect is additive. And at the end of the day, the result is we kill a large number of tumor cells and a much smaller amount of normal cells. So that's the theory. That's why all these years we've treated people with external treatments with many weeks of courses of treatment. And unfortunately, over time, particularly with prostate cancer, we found that the more treatments we give, or the higher total dose that a person gets, the better our outcomes are, the more men we cure of prostate cancer. So unfortunately, these already long courses of external radiation treatments have just gotten longer over the years. So back in the 80s, radiation treatments for prostate cancer, usually men got something in the range of 33 treatments or 6 weeks of treatment. In the 90s, that increased to 35. In the early 2000s, I think 37 treatments would have been the most common. And by about 2008, 2010, it would have been most common to get about 39 or 44 treatments. So we're looking at about 8 to 9 weeks of treatment. So basically, with time, treatments got longer and longer, and have over time become increasingly inconvenient for patients. So the question then came up, well, can external beam radiation treatment regimens be safely shortened? I mean, the question being, are shorter courses of radiation treatment as effective as the standard long 8-week courses, and do shorter courses have more long-term side effects, or are they just as favorable in terms of the side effects? And just recently, in the last 2 years, we finally got the answer to that question. And actually, Canada was one of the countries that partook in this. There's 2 big studies came out looking at whether we could shorten down the courses of radiation from 8 weeks, which was the standard, down to 4 weeks, so cutting it down by half. And one of the studies that looked at this was a large Canadian study called the Prophet study. The other one was done in the UK. And basically what both studies did was they got large numbers of men, 1,000 or more men, and randomly assigned them to a 4-week course of radiation or an 8-week course of radiation. And fortunately, both studies showed, that's what the graph showed, that there was no difference in the cure rates or the long-term outcomes between the 4-week course and the 8-week course. So that 4-week course was just as effective, and the short course also didn't show any difference in long-term or serious side effects. They were just as favorable. There is a little bit of higher short-term side effects with the bowels in terms of diarrhea and things like that, but that's limited in a short period of time. So on the whole, the shorter, kind of half the duration of radiation treatment has now been definitively shown to be just as effective as these long courses that have been putting men through for many years. So now, just for the last year or so, the 20 fraction course or a 4-week course of radiation treatment is now considered one of the standard options for prostate external beam radiation treatment across the world. And we're now using it in Victoria. So now in Victoria, when men come in, there's a number of different options. I mean, some men will be recommended a 20-day course of radiation. There's a 28-day treatment regimen, 37 and 39, and which choice is best for a particular man depends on a number of factors. And so, a given man may be recommended a certain option, but certainly the 4-week or 20 treatment course is now one of the standards, which is great for men from up island. I mean, it's still quite inconvenient if you're not from Victoria to have to come and stay down here for 4 weeks, but certainly it's a lot more convenient than having to stay here for 2 months. So that's the first kind of big change that's kind of happened in terms of the standard options for radiation treatment, is that basically our treatments have become shorter. And then I was going to just mention, the next thing I was going to mention along the same lines is a new kind of treatment, which would still be considered experimental, and it's called Prostate Stereotactic Ablative Radiotherapy. And so we call it SABRE for short, is the acronym. And basically this just takes the idea I just talked to you about a shorter treatment course kind of to the extreme. Basically, the idea of this is using all our kind of fancy technology we have to deliver radiation treatment, to deliver the external radiation treatment for prostate cancer in a much more precise, accurate, and sort of focused manner. And because of that, we're able to vastly reduce the number of treatments down. And so each treatment is of a very large dose. And so typically when we do this kind of treatment, we're talking about maybe 5 treatments or less sometimes. The thing is, so it's the good thing is when you give fewer very large treatments, there's some data that it may be more effective against prostate cancer and may be easier to tolerate. But when you're given, a small number of very large doses of radiation, you need to be really certain that you're hitting the mark. If you don't hit the target appropriately, you could really reduce someone's chances of being cured of cancer, or you could really increase their risk of having damage to nearby organs and having bad side effects. So basically, I just thought I'd quickly take you through how this works. And keep in mind, this, unlike the first thing I was talking about, the sort of 4-week course of radiation treatment, this would be considered experimental. But we do have it at the Vancouver Island Center. So in order to give this kind of treatment, there's sort of 3 components to it. One is we have to make sure we aim the beam correctly. That is, we have to have the patient set up and very accurately and have the prostate gland targeted very accurately each day, so aim the beam correctly. We have to have very focused or conformal delivery of the radiation, so the radiation has to be very focused on the target of the prostate gland. And the last thing is we have to make sure that to do something to try and minimize the chance of the man moving on the treatment table while the beam is on, or else we're not hitting the right spot if somebody moves. So we have to make sure we aim correctly, focus the radiation on the target well, and make sure we actually hit the target. And so I'll just take you really quickly through it. In order to make sure that we set the person up properly, we actually, before we start the radiation, we bring people in and we use needles to put in 3 little gold seeds into the prostate gland. That way, when they're actually lying on the treatment table and we're setting them up, we can take pictures and we can see those little gold seeds. And so we use those to help make sure that we got the person in the right place. So the gold seeds kind of tell us where the prostate gland is. Our machines have what's called a robotic table or robotic couch. So once the machine sees where the seeds are, if they're not exactly where they should be, this couch will move the patient or the patient's prostate gland in the right directions, exactly the right amount to get the patient in the prostate gland in the exact right place where it needs to be to get the radiation treatment. And then once the person's in the right place, we confirm that they're in the right place by doing a CAT scan. And here you can see these 2 little seeds in there where they're supposed to be. So that's how we kind of aim the beams. And then we deliver a very focused dose of radiation. And again, this part is kind of techy. It's very complicated, but it uses a very advanced form of radiation delivery. We call it VMAT. Basically, the machine makes a big arc around the patient with the beam on the whole time it's there. There's lots of moving parts and things, but at the end of the day, this is kind of what it looks like. The radiation dose is very tightly focused where the prostate gland is, but you get very little radiation to the organs nearby, the rectum or the hips and things like that. And then finally, we try to make sure that the patient doesn't move while the beam is on. And there's different ways that this can be done. Some places will actually go through the effort of implanting fancy transponders into the prostate gland to track where it moves. Other places will use robotic radiation machines to move with the prostate gland. Our technique of doing this is just making the treatment extremely fast. Because our idea is that if the radiation is delivered in an extremely fast amount of time, the chances of somebody moving in that amount of time is very slow. So we use a way of delivering the radiation where each treatment only lasts 60 seconds. And so the idea here is that in 60 seconds there shouldn't be very much movement. And so as I said, this is an experimental form of treatment. But the studies that have been done so far would suggest that it's very effective. And this is just some data that comes out of the BC Cancer Agency. Actually, this came out of Vancouver, and they compared some outcomes with SABR with Radiotherapy, and the 2 seem very close in their ability to keep man disease free. And on this one, this is where it's compared with the regular old external beam radiation treatment, and the SABR actually seems to be a bit more, possibly be a bit more effective. But as I said, this is considered experimental, basically all through North America. In Canada, I don't know that there's very any centers that are giving this treatment unless it's on a clinical trial. We do have a clinical trial in Victoria, or actually BC-wide, that's looking at this treatment, and it's called the ASSERT study. And so some men are eligible for this study. If a man is eligible for this study, it's a randomly assigned treatment where if you flip heads, you get the saber treatment. If you flip tails, you get the conventional radiation treatment. The idea here is this study will compare the two and give us an idea how this experimental treatment stacks up with conventional treatment. So that's the kind of the second big thing that's changed is our ability to give these sorts of experimental treatments that are very quick for men. And then the last thing I want to mention about localized cancer and how things are changing is efforts to reduce the side effects of radiation treatment. And last time I was here, I spoke about this a little bit. It's about, what I'm talking about here is it's actually a product called Space OAR Hydrogel, which I'll explain what that is. When I was here last time, I talked about it a little bit more as something that was on my wish list. And actually since then, 2 years now have gone by, and we actually have this, and we're actually using it in patients, partially through the help of the Island Prostate Center as well. So this is an example of something that's, over a short period of time, went from being to something that we hoped we would get to something that we're actually using in the clinic. So what this has to do is side effects of external radiation treatment. So over the years, there have been a lot of advancements in technology that have allowed us to reduce the side effects of radiation treatment. But the thing is, most of those advancements, or most of the improvements in side effects have largely been driven by improvements in advanced technology. So, for example, our new advanced computer planning platforms, our advanced radiation delivery techniques, our advanced imaging, these are kinds of the things that kind of drove the reduction in radiation side effects over the years. But what I'm going to talk to you about now is something that's completely low-tech. This is what I want to talk to you about now is a product which is an example of a really innovative use of a basic technology to give us big improvements in the side effect profile of radiation treatment. And so in order to explain that to you, I got to explain why people get radiation side effects with the bowels to start with. And this diagram basically shows this is the prostate gland. Directly behind the prostate gland sits the rectum, the bowel. And when we give radiation treatment, no matter what technology we use, we always get a little bit of radiation, high dose of radiation around the prostate gland. And so the problem is, no matter what we do, there's always a little bit of the bowel, a little bit of the rectum that's going to be in that high dose radiation field. So a little bit of the bowel will get a high dose of radiation, which results in some of the side effects that men experience. Some of those side effects being short-term, some of them being long-term. So the solution, the sort of simple solution, which I think is actually very elegant, is instead of using fancy technology, the idea is let's just try and move the rectum out of the way of the radiation. And so what it is it's a product that gets injected in that space between the prostate gland and the rectum, and basically just moves the rectum out of the way so that that front wall of the rectum is no longer in the high dose area of the radiation treatment. And so if it's away from the high dose of radiation, then people should get less side effects. Very simple. So basically what it is PEG. It's the same stuff that you give little kids for constipation, polyethylene glycol, and they just made a gel out of it. And they basically made this gel that when it contacts with an accelerant, it immediately solidifies. And so basically, it's a procedure where we put a needle in between the prostate and the rectum, and we inject this stuff in, and as soon as, along with the accelerant, as soon as they contact each other, it solidifies and forms this space between the rectum and the prostate gland. And so that's what it looks like on an MRI. So it's an MRI that shows the prostate gland and the rectum, and then we put the gel in. There's this white stuff in between that's pushed the rectum out of the way, and it only stays in place for it starts to degrade and dissolve in about 3 months after insertion. So it's in place just long enough for a course of radiation treatment, and then it degrades and goes away. And people don't feel it. The patients we've done don't notice anything from that being in place. But because it moves the bowels, the rectum out of the way, it significantly reduces the long-term side effects of radiation treatment. So this is just one of the studies that shows basically men, the blue line are men that had radiation treatment with the gel in place, and that 4 years afterwards, None of them have any kind of significant long-term side effects with the bowels, as opposed to the red line, where about 6 or 9% in the long run had some significant long-term side effects with the bowels. So it makes a big difference. And this just shows the quality of life. If the men who never had this stuff inserted, their quality of life with their bowels kind of slowly decreases with time because of bowel troubles they might have. But if you have the gel in place, your bowels kind of recover and your quality of life basically recovers to baseline. And for some reason, it also seems to help with the bladder in the long run after radiation treatment. We don't know why, but it helps to prevent leakiness or incontinence as well. And so with the generous support of the Island Prostate Center, we were able to use this product in 20 patients. So 20 patients at the Victoria Clinic have had this inserted successfully. All have done well with little or no side effects, and I'm happy to say that because of that success, the plan now is to move forward with a pilot program where we're able to do, hopefully we're able to do 50 cases per year for the next 3 years, see how that goes, and if that goes well, then hopefully this will be a long-term thing. Yep.
How many, I don't have a sense of how many cases you have a year.
Prostate cancer?
Yeah. In this hospital that
In
you
this
treat.
hospital. So of all kind of cases of prostate cancer in this hospital, we probably get about 25 referrals a month. So a couple hundred a year.
Okay.
Yeah. Yep.
Would there be any need to use this gel with, say, brachytherapy?
That's something that we're looking at too. So there is some data that it may be useful for brachytherapy. Brachytherapy, if we don't tend to get as much troubles with the bowel with the brachytherapy as we do with the external treatments. But yeah, definitely, it has been done before. There is some data that it helps with the brachytherapy, and so it's something we want to look at. And we actually want to look at it for other cancers too, not just prostate. There's other kind of like gynecological cancers, for example, where women can have a lot of troubles with the bowels in the long run, and we'd be able to use this gel for that as well. But those would be kind of more experimental uses, but that we're definitely going to look into for.
Go back.
Yeah.
Is the radiation equipment checked for consistency in terms of output?
It is, yeah, and we have a whole host of physicists that take care of that every day, and so the output, everything's also recorded too. That's the other thing. So it's easy to go back and see if there's any problems. Anything with the radiation machine is recorded permanently, basically. But yeah, we have physicists that commission and take care of the units, and QA is performed daily, actually per patient. QA is performed to make sure it works.
How long have you been using this gel?
We just in the last year. So, like I said, 2 years ago when I came here, it was a thing that I wanted on my wish list, and I chatted with Leanne, and we were able we were fortunate to have some help getting some gel to use, and in the last year we've done these 20 patients who've done really, really well. And so our hope is within the next 6 months to continue on with more. Yeah, well, things are always changing, that's the thing, right? So that's kind of the third thing for the localized disease, I think, that has really changed. Those are 3 things that have changed just over the last 2 years in terms of giving radiation treatments for localized disease. But if I have time, which I think I do, I want to quickly switch gears and talk about some changes in how we use radiation for the other proportion of men who we see whose cancer has already spread. And I think this is actually, in some ways, even more exciting because classically, disease that has spread has not really been the realm of radiation treatment. Cancer that has spread, the mainstay of treatment has generally been medicines. A lot of you may have be on or been recommended hormone therapy. That generally tends to be the mainstay of treatment, and radiation hasn't been used a whole lot, but now we're kind of making some inroads to this area. So I was going to talk about 3 kind of developments in the treatment of cancer that's spread. One is this idea of treating the prostate gland in disease that's metastatic, in disease that has spread. And so when we talk about disease that has spread, as I mentioned, the mainstay of treatment is what we call systemic treatment. So systemic treatment means a treatment that goes to the whole body. And so that generally means for prostate cancer, hormone therapy or androgen deprivation therapy, medicines that block the male hormones in the body, and more recently, that's often combined with chemotherapy or other kinds of medicines. In general, the prevailing opinion for many, many years has been that when someone's prostate cancer has spread, it is metastatic, there's no real role for local treatment to the prostate gland itself. There's no point in taking out the gland or giving radiation treatment to the gland. The idea of it was that the horse is already out of the barn. There's no point in treating the prostate gland. You need something that's to go everywhere. But we're starting to think that maybe that's not the case. And there's a few reasons why, even though the horse is already out of the barn, there's a few reasons why treating the actual prostate gland itself may still be useful. Even if the cancer is spread, it may be that the substantial bulk of the cancer may still be in the prostate, and by treating that, you may help to prevent symptoms that someone might develop in the pelvis. If that is truly the bulk of the disease, treating the gland may reduce further spread of the cancer. And the other thing is we're starting to understand more about how these tumors work, and there's some evidence that the actual prostate gland itself may release substances into the body that promote the growth and survival of distant tumors in the body, tumors that are elsewhere. And so by treating the prostate gland, you may help to reduce these factors and reduce the growth of the cancers that spread. And then the other thing is there are other cancers where we've found that this works. And a great example is kidney cancer, where with kidney cancer, even when someone has kidney cancer that has spread to many parts of the body, we know that there's still a benefit to taking out the kidney. For some reason, taking the kidney out makes men live longer, even when the kidney cancer spreads. So maybe the same thing holds true for prostate cancer. And we don't know for sure, but two large kind of retrospective, when I say retrospective, I mean studies that have looked back in time, two large studies looking at big databases in the States has come out in the last couple of years that suggest that even in men whose cancer is spread, they may live longer if the prostate gland is treated or removed. And there's two of them. One is from this group in the States looking at a database called SEER, and they basically compared thousands and thousands of men. The first two curves here are men that had either surgery or brachytherapy along with hormone therapy for their cancer that had spread, and the bottom curve is men who just had hormone therapy alone. And the men who had something done to the prostate gland lived a lot longer and had a lot less problems, or a lot less died less often from prostate cancer. So that's one study that showed that, and then this is another one looking that from the American National Cancer Database. Basically the same idea. Men who had radiation of the prostate gland as well as hormone therapy seem to live longer than men who have just hormone therapy alone. Now, this is not definitive by any means, but certainly these two studies would suggest that maybe treating the prostate gland, even in the situation where the cancer is spread, may be a benefit. Because they're studies that are retrospective, i.e. looking back in time, it's not definitive. The results could be simply due to bias. The truth is, probably in both those studies, the younger, healthier men with less aggressive disease would probably just happen to be the guys who got treatment. The older men who were kind of sicker or had other problems probably were never offered treatment, so there's already kind of an imbalance to start with. So the only way to really know if it helps is to do a prospective study, i.e. like a study going into the future, ideally randomizing between the different treatments to see if it's truly beneficial. But today, based on the available data that we have, there is data to suggest that it's useful, and therefore nowadays, definitely we are considering it in every man that we see nowadays that has cancer that is spread. It is considered. We don't necessarily offer it to everybody or give it to everyone, but it's considered.
If prostate cancer spreads, whatever that means, is it always, like if it goes to some other place, is it still prostate cancer, or does it become another kind of cancer?
It's still prostate cancer. It's just prostate cancer that's gone to another site.
Okay.
Exactly. And which usually, for the most part, is the bones. It usually spreads to the bones where it goes first. So that's definitely a different paradigm. That's a major paradigm shift. Whether it'll be something that will hold true in the long run, we'll have to wait and see, but that's something that's changed a lot. The other area that's changed a lot that I was going to mention is, we talked about whether it's useful to treat the gland itself in cancer that's spread. The other area that's changed or is controversial in some way is, do we treat the sites of spread? And kind of in the same, just like with the last example, we were talking about the mainstay of treatment of prostate cancer that is spread is medicines, hormone therapy, with or without chemo. And again, it's just like with the last example, aggressive treatment to every site where the cancer is spread was never thought to be helpful. Say I have a prostate cancer that's spread to 2 or 3 different sites in the bone. We've never tried to aggressively treat those 2 or 3 different sites of spread, because it was always thought that if you treat those couple of spots aggressively, it's not going to make a difference. New spots will just pop up. So again, the treatment has always just been medicines. But more recently, there is some data to suggest that if a man has prostate cancer that's spread to just a couple of different sites, say 2 or 3 different sites in the body, maybe treating each of those sites aggressively, either with high-dose radiation treatment or even surgically dealing with them, maybe it'll make men live longer. And this strategy is actually, we do this with other cancers. Colon cancer, there's a lot of men out there who have colon cancer that spreads to, say, the liver, and we actually take out the cancer that's in the liver. Sarcoma is another type of cancer where if it spreads to the lungs, often we will take out the cancer that spreads to the lungs. So this disease state of just having a couple of areas where cancer is spread, maybe 1, 2, or 3 areas of spread, we call that oligometastatic disease. And all that means is few areas of spread. And that's a particular group of men that we're looking at that maybe we should be treating them a lot more aggressively and not just putting them on hormone therapy. And so again, the aggressive treatment we're talking about for this goes back to that what I was talking about before, SABR. That very precise treatment I mentioned earlier on for treating the prostate gland. Well, you don't have to use it to treat the prostate gland. You can treat any tumor with this technique. And so basically all SABR is a very precise and accurate way of delivering high-dose radiation treatment. In this situation, the idea is to deliver it to every area where the cancer may have spread. And we have a study looking at this in BC as well. It's called the SABR-5 study, and it's for men with cancer that's spread to 5 sites or less. And if men are on the study, we basically aggressively treat each site of cancer. Yeah.
What's your criteria for knowing where it has spread or how many sites there are?
So it depends on the type of cancer. For prostate cancer, it would be putting people through, at the very least, a bone scan or a CAT scan. And actually, to be honest, more recently, we have access to PET scanning, which is kind of the most accurate way of detecting cancer, and PET scanning for prostate cancer. So for me, I've generally been sending men that are maybe eligible for study to Vancouver to have PET scans so I can document exactly how many lumps there are and where they are and what they're doing. Yep.
We went down to Los Angeles for our PET scan because Vancouver was down.
Yeah.
And I was told that a certain percentage of people that doesn't work for them. I apparently was one of them.
It's true.
I think 5% or whatever.
Mhm.
So in that case, how do you tell where it's going?
So you can't.
I'm on the high hormone treatment, as you're well aware.
Yeah. So no, and it's true. I mean, about 5% of people, the kind of PET scanning that we use for prostate cancer will work for about 95% of prostate tumors, but between 5 and 10% don't take up this contrast agent that they show. So for men with that, in that situation, the only option is to go with the best available imaging, which would be bone scan, CAT scan, or whatnot.
So would you do that more often than a patient that actually should, I don't know, right? So would I be due for a bone scan sometime down the line just to make sure it hasn't?
You might,
Just a PET scan, or would you try another PET scan? I mean, if a PET scan
we
fails
probably
once,
wouldn't,
would it
if
fail
it didn't work
twice?
the first time, we probably wouldn't try it again, but, generally speaking, when we're following somebody, we usually will go by the PSA first.
Yeah.
And usually we'd only reserve imaging if the PSA wasn't cooperating.
Okay.
Do you have a question?
MRI is not a...
MRI is good too. So yeah, certainly. I say PET scan because we have it now, and so we become dependent on it. But certainly before the PET scan was around, I was sending people for MRIs for this purpose as well. Yeah.
If you have radiation therapy and then the PSA starts to rise, what are the options at that point? I mean, if it's still considered localized, can more radiation?
Oh, if it's still in the prostate gland itself? It's possible. So that's a very complicated situation. But certainly more radiation is possible, surgery is possible. There's cryotherapy, which is freezing the prostate gland, that's possible. There are many different options. And generally speaking, we would explore all of them. Or the fallback is hormone therapy. So we look at all the options in that situation.
Hey, if someone had a CAT scan and a bone scan, and let's say both of those came back as negative,
Yeah.
would you recommend that they go for a PET scan?
It depends on the situation. So if it's somebody that's generally not, it depends on what the situation is. So if someone's just diagnosed with a prostate cancer and are looking at curative treatment, and they've had the bone scan, the CAT scan, and they're negative, we would usually accept that as being truthful. In that situation, I would only send someone for a PET scan if there was something equivocal on the CAT scan or the bone scan, or something that didn't make sense, something out of the ordinary, then we would send someone. So I'll just go on real quick here. So we do have the study looking at aggressive treatment of every site of disease in men who've had a few, less than 5 sites of spread. And this is just an example of a man that I had. So this is a man that had prostate cancer, and he had only 1 site of spread. So this is the skull, and this is actually a PET scan. So this is the skull, and the only site of spread he had is this little hot spot that was there, and his PSA was rising. 10 years ago, we would have deemed this incurable disease or difficult to manage disease and put someone just on hormone therapy. But in this situation, we decided to give him SABR. So this is just a picture of the SABR. So this is where the very high dose of radiation goes. It's radiation that's delivered in 5 treatments. He had this treatment. It's been about 8 months since he's had his treatment. His PSA has dropped to near undetectable levels after completion of the SABR. His imaging shows no disease in the skull. So who knows what's going to happen with time? But certainly this, at the very least, this is at least hopefully delayed. Further treatment. Hopefully he'll stay out there for a long time. So as I mentioned, SABR can be used for treat up to 5 sites in appropriate patients. Often it's bone, but it could be liver, a spot in the lung, a spot in the lymph node. It is technically demanding. It's a very high resource utilization, so it's a difficult thing to do. It takes a lot of resources, which is why we're only doing it on clinical trials right now. It takes a lot of time and a lot of money to do this right now. But there is a study suggesting it helps. So this is one of the first studies that have come up looking at it. This group took a bunch of men that had up to 1, 2, or 3 sites of spread, and half the men they gave the SABR treatment to every site of spread. The other half of the men, they kind of watched them to see what would happen, and what they found was the men who had the SABR, they were able to delay the need of hormone therapy in these men by about a year, which is pretty good. If you're able to delay, because hormone therapy has a lot of side effects, and it doesn't work forever. And so if you're able to delay that for men by selectively zapping some of the sites of spread, I think that's definitely a win. It's definitely a benefit for men. So that's again another kind of experimental thing. And then the last thing I was going to mention is radium. And this is kind of the last sort of big change in the way that we look at radiation treatments for prostate cancer that's come out in the last few years. What radium is a new treatment option for men with cancer that is spread, and specifically for men who have cancer that's spread that's progressing despite being on hormone treatment, what we call castrate-resistant hormone therapy. And when the disease gets to that point, we have a few different options, and radium is one of the new options. And what radium is, radium-223 is an intravenous form of radiation treatment, so it's completely different. It's not being zapped from the outside. It's not radiation implanted like brachytherapy. This is an intravenous form of radiation treatment, and basically it's an injection that's given, and it's incorporated into the bone at sites where the cancer is hanging out in the bone. So this kind of shows it. So basically what radium does is it mimics calcium. And so when you inject it into the body, it selectively goes to the bone, and the bone thinks it's calcium and incorporates it into its bone matrix. The thing is, most of men with metastatic prostate cancer that's spread, particularly cancer that's spread that doesn't respond to hormone therapy anymore, most of the cancer is usually in the bones. That's where the vast majority of the cancer is. And so basically, so this gets taken up in the bones in areas where there's cancer in the bones, and once it gets into the bone, it releases what's called an alpha particle, which is just a very short-range type of radiation, and that goes down and damages the DNA of the cancer cells in the bone and helps to treat the cancer. It's good for men where the majority of their cancer is in the bones, which is most men with metastatic prostate cancer. So it's given as an injection once per month for 6 months. Very well tolerated. The side effects are quite mild. Most men don't notice much at all. Men that do have side effects, a small number will get a bit of diarrhea, a small number get a bit of nausea. But similar to chemotherapy, it can affect the blood count, so we do have to keep an eye on those to make sure the blood levels don't go low. It's been proven to make men with this form of prostate cancer live longer. It's been proven to reduce the risk of fracture in men who have prostate cancer that spread to the bone, and it's been proven to help men maintain a better quality of life. And so this has been available in Victoria now for, I think, about 2 years, 2.5 years, and it's now actually just recently, men can also get it in Nanaimo as well. So that's radio.
How does it find the site?
It's because the body thinks it's calcium. Any calcium that you have in your body, it goes to the bone. Calcium automatically goes to the bone, and calcium preferentially goes to areas of bone that are damaged. And so the body thinks, so areas where there's a tumor in bone is kind of damaged, and so this pretends it's the body thinks it's calcium and just puts it into areas where there's bone tumor automatically. It works well, and what I think is neat about it, this form of kind of injectable or systemic kind of radiation, this is just the first example of it. There's a whole bunch of new ones coming down the pipeline. There's a really good one called PSMA that I'm hoping that we'll get sometime in the next year or so that I think may even be better than radium. So there's a whole bunch of these new kind of radiopharmaceuticals that are coming up that are kind of tailored to treat various cancers. And I think it's a really exciting area of radiation treatment. And radium certainly the first kind of standard one that we're using in prostate cancer. Yeah.
Sorry. So that treatment, like you said for me, I'm just sorry about picking on me, that you didn't want to do radiation near my pelvic area because the damage has already been done.
Yeah.
So could I take that and then stop on the hormone therapy, or
this will only treat cancer that's in bone, and right now, whether it's useful for somebody who's right now it's only licensed to be used in men in whom the cancer is progressing despite hormone therapy. So for later men with sort of later cancer, but we are looking at it now. We always start with new drugs and new treatments in late stage disease, and then we try it earlier and earlier and earlier. So it is being looked at in your situation now. We just don't know if it's useful yet in that situation. So that's all I was going to talk about. Basically, and this kind of summarizes all I was going to talk about. And basically, how the landscape of prostate radiation treatment has changed in the past few years is standard external radiation treatment for prostate cancer. Localized prostate cancer is now about half as long as it used to be, and we're working on new techniques to shorten that even further. New techniques, not all of which has to do with fancy technology, have now been developed to reduce the side effects of radiation treatment, and we're now starting to incorporate some of these new techniques into daily practice. Now, which is completely different than when I was trained, we now offer treatment to the prostate gland in men whose cancer is spread, and that we think may be improving survival. Again, way different than when I was trained. We now offer aggressive, precise, saber treatment to selecting men whose cancer is only spread to a few sites. And again, I think that we're making outcomes better for men in that way. And also now radiation treatment for prostate cancer just doesn't refer to local treatment anymore, external beam or brachytherapy. Now we're starting to use these systemic forms of radiation treatment. I think that's really only the beginning. I think that's an area that's just going to get bigger and bigger with time. So things are really changing, and it's an exciting time to be a radiation oncologist, that's for sure. So that's all I had to say. Yeah.
With respect to the 4-week and the 8-week program for the radiation, is the total radiation going to be the same?
It is. The biological dose, like the dose of the tumor, is actually the same. It's just with a 4-week course, you're getting a bigger dose every day. So at the end of the day, it's the same.
How long after external beam radiation should a person be monitored with PSA?
Well, generally speaking, we would say lifelong, but not necessarily at the cancer agency. So, unfortunately, we don't have the resources to keep following. I mean, we used to, but not anymore. We don't have the resources to keep following men for long periods of time. In the old days, we used to follow men for 5 years after treatment and then discharge with a family doctor. We don't even have the resources to do that anymore, that long anymore. So nowadays, we discharge men, usually very quickly after treatment. But certainly, we discharge men to the care of their family physician or urologist with instructions on monitoring, and we would recommend that people get monitored lifelong. After a few, at first I recommend check the PSA every 6 months or so. Eventually, if things are looking good and it's stable, every year is sufficient. But in the long run, I would recommend at the very least someone should have their PSA checked once a year and should have a rectal examination done once a year.
kind of PSA reading are you expecting or hoping to get after radiation therapy?
So, so that's a good question. So, where your PSA should be after radiation treatment, or after treatment, depends on the treatment that you've had. So, after surgery, for example, we expect a much lower PSA. So, if someone's had surgery, ideally we want to see a PSA close to 0, and certainly we would consider a PSA after surgery, a PSA above 0.2 to be a treatment failure. Radiation is a bit different. Our definition of failure for radiation treatment that's commonly used by most of us is if the PSA goes 2 points above the lowest it ever got. So if your PSA ever did go down to say 0.1, if it ever went above 2.1, then we would count that as a treatment failure. If your PSA came down to 1.5 and that was the lowest it got, it would have to get to 3.5 before we would count that as a treatment failure. So that's kind of, strictly speaking, that would be our definition. So that's what we look for. That being said, I wouldn't, I don't always hold to that. I won't necessarily get worried all the time if someone's PSA goes 2 points above the lowest. Sometimes we wait longer.
I got a question for you. I'm on a drug trial, and my PSA is being checked fairly regularly. The readings that are coming, some of it goes to the states for analysis, and some of it is local, but the numbers are different. Any explanation for that?
Yeah, so it depends on how they test it. So there's different tests that can be used, and some of them are at varying levels of accuracy. There's sort of all tests that can ultra sensitive assays. There's regular assays, and it depends what they're using. My guess, depending on where they send it in the states, I think I know which trial that you're on, but my guess, I would probably guess that the place you're sending to the states probably is a more accurate assay. But to know, I'd have to actually ask them which one they're using. But
Atlas.
yeah, the one in the states I think is probably more accurate.
One
Sorry, you're here.
I was just wondering, like when you, whatever form of radiation you use, the external beam of radiotherapy, so you're radiating the prostate and you're killing the cancerous cells. The other cells that are not cancerous, they are exposed to the radiation, and you're saying that if it is really strong, it can damage them. But those cells that are not cancerous, they're supposedly healthy, and they have been exposed to radiation, which initially isn't damaging. Over the long term, because they've been exposed to radiation, wouldn't that predispose them to becoming cancerous?
Oh, certainly, yeah. Certainly. There's a whole host of side effects that a person can get from radiation treatment, and those side effects happen because of damage to normal cells. And causing cancer, carcinogenesis, is a well-known effect of radiation. So certainly radiation can cause cancer, and external beam radiation treatment has been associated with that. Even external beam radiation treatment for prostate cancer, it may put someone at an increased risk for developing, say, a bladder cancer or rectal cancer. Fortunately, it's a relatively rare phenomenon, and it also takes a lot of time. It takes time to develop. So, for a radiation-induced cancer, we generally think they're rare to start with, and for those rare men that do develop it, it usually takes 15, 20, 25 years to develop. So particularly, so it's a big issue, say, when I treat a woman who's 22 years old with cervix cancer, it's a huge issue. But when I'm treating a man who's, say, 75 years old with prostate cancer, it's less of an issue because a lot of them will probably pass away of something else before they were going to get
They basically just stay healthy, kind of.
Yeah. But the causing the cancer is fortunately fairly rare, and as I said, many of the men that have prostate cancer wouldn't have a lifespan that would make that a big concern for them. But it's the other side effects of cancer that are of radiation treatment are more worrisome. We can cause damage to the bladder and the bowel, and some of the damage that we can cause can be irreversible. Fortunately, the normal cells are better able to repair themselves than the cancer cells. That's one reason why we get that differential I talked about. Cancer cells radiation works by damaging DNA or genes of a cell, and tumor cells, cancer cells, can't repair their DNA very well, whereas normal cells can. So normal cells do repair themselves, but certainly we can cause long-term side effects. That's why we take all these efforts to try and focus and conform our radiation to the area we want to treat better, try and reduce the normal tissues from getting radiation treatment or being exposed to radiation. These are the efforts that we make.
Is it true that it's difficult to do surgery after radiation?
It is difficult, and again, for the same reason, is that after once had radiation, the tissues in the area aren't the same. Radiation causes scar tissue to form, the tissues kind of get stuck down, and it's difficult for a surgeon it's definitely more difficult for a surgeon to do surgery in a irradiated field. So certainly it's more difficult. It's not impossible. It can be done. I often get asked that, but if I have radiation treatment doesn't work, can I still have surgery? You can. I've had patients that have had surgery, but it is a more difficult surgery, and the risks certainly go up. But it can be done, and it should be done by a surgeon that's well versed in operating in a gland that's been treated with radiation, but it can be done.
Does the robotic help?
That I don't know. In that situation, I don't know that there's enough cases. Like they don't do a lot of surgery in radiation-treated glands, so I don't know that they've had enough. If they get enough cases to say whether the robotic is any better than the open. So that's a good question. I can say that the robotic, hasn't really panned out in as it's not as much of a benefit as they were thinking it was going to be. The thinking with the robotic was that it was going to help them in a lot of ways because they get better visualization and things like that. But it's turned out that it hasn't actually been as useful as they were hoping for in a lot of those areas. Where it has been very useful is the recovery period. From what I understand, and I'm not a surgeon, I think surgeons know this better than I do. From what I understand, because the robotic surgery is a laparoscopic surgery, not a big incision, that the recovery period is much faster for laparoscopic surgery than open surgery. But I don't know if it's all that much more useful in getting the whole gland out or that kind of stuff.
Would you consider brachytherapy on somebody whose external beam therapy wasn't considered successful?
We can do that. We can do that. Again, it's anything you do. Any second treatment you have to the prostate gland, whether you've had surgery and then have radiation, or whether you have radiation and then have brachytherapy, or radiation and then have surgery, or whatever, any second treatment you have is more fraught with risks than the first treatment. So certainly the risks go up, but we are finding that brachytherapy is an option, and I have there's different kinds of brachytherapy, and I have patients that have had brachytherapy for external beam failure, so we've done that a few times. And the other thing is SABRE is also becoming an option as well for external beam failure, so it can be done. Going back.
Sorry. So if you had radiation or your prostate removed, what makes the decision to have one or the other, or is it just your doctor at the time?
Whether to have surgery or whether to have radiation?
Yeah.
Well, it's your choice, to be honest.
I didn't know I had a choice. I'm just saying, what makes that choice?
Yeah, in an ideal world, and what we recommend nowadays is that we recommend, I think most of us recommend that anybody with prostate cancer who's considering curative treatment should see a urologist to talk about surgery, and should also see a radiation oncologist to talk about the radiation treatment options, and then be presented with the advantages and disadvantages of each of the options, and then make their own decision at the end of the day. I try not, personally I try not to make a real recommendation of one treatment over another. I try to tell men what all the options are for them. I do try and, nobody just wants, I think people want more than me to just show them a menu of what the options are. I think that they want to know what do I think there might be well suited for, so I do offer that. If I see somebody who has prostate cancer, I'll tell them all about all the options, but I will throw in, like, if I think that you're a better candidate for surgery than you are brachytherapy, I'll tell you that. It doesn't mean you can't have brachytherapy, but I'd say, I think you're probably a bit better suited to option A rather than option B. But at the end of the day, it's up to you which option you have.
Yeah, because I never had the option. I was just, surgeon and then right away removal, right? So
that does happen.
That's what I'm trying to find out now.
That happens less and less. That used to happen a lot, and over the years, a lot of times I think a lot of men were having surgery and never getting referred to us. And I have to say, I think our surgeons are excellent on the island, and that doesn't tend to happen a lot.
My surgeon said, you don't want surgery.
You
want to go to radiation and then brachytherapy with hormone therapy through the whole thing.
Yeah.
So he was pretty upfront about it, saying there's too much, you can't, surgery's not an option. So.
It seems as though the more aggressive the cancer, the higher the DAT number, the more the surgeon wants to do surgery rather than going the radiation.
I don't know.
They don't want to take a chance to do
It really varies, you know. I mean, when I was trained, we were always trained that the more aggressive cancers, the higher the Gleason score, high Gleason score cancers, high stage cancers. I was trained that we would deal with those with radiation or hormone therapy rather than surgery. That being said, today in 2018, I really don't think one treatment's any better than the other. Like, I actually think surgery can be an excellent treatment for high risk, high Gleason score cancers. I think that radiation treatment with hormone therapy can be excellent treatment for it. I think they, in general, I think they're all excellent options. It's just a matter of picking the right option for the right person. When you talk about surgery for high-risk cancers, I think surgery for high-risk cancers is a great treatment as long as somebody realizes that if you have a high-risk cancer and you have surgery, there is a risk that you may need to have radiation treatment afterwards. And as long as you go into it knowing that, I think it's a great option.
Has there been any big change in the application of radiation following surgery where there's positive margins or suspicion that the PSA isn't dropping the way it should?
Yeah, so we're actually waiting right now for the results of the study. A really big study was done, and it just finished last year, and we participated on it. It was a big study called the Radical Study. So when someone has surgery and they have the gland removed, sometimes there's high-risk features that would suggest the cancer is at a high risk for coming back. And so they might have what's called positive margins, which means that the cancer wasn't removed in its entirety and there's some cancer cells left behind, or there's some other features that might portend a high risk of the cancer coming back. And what we've never known is whether those men are better served by having radiation right away because we know they're at high risk, or whether we should wait and kind of see what the PSA does, and if the PSA goes up, then give radiation. And so that question is what this study is looking at, but we're waiting for the results. So that will hopefully answer the question on whether men in that situation need to have radiation right away, or whether it's safe to kind of watch things and treat when they do.
Just a question on the CT scan with contrast.
Yep.
That's for organs, right? That tells if you spread into your organs. Does it also for your lymph nodes?
It does. So I mean, the CT scan looks, and we'll look at everything, but you know, we generally would put someone with prostate cancer through both a bone scan and a CAT scan. And generally, I'm looking at the bone scan to look at the cancer spread to the bones, the CAT scan to look if it's spread to the lymph nodes or the organs. But it will show spread to the bones as well, just not as well as the bone scan does. Yeah.
You showed me a really nice graph at the beginning that showed why you should do many treatments.
Yeah.
And then you told me you're not doing many treatments.
Yeah. It's true, and so that was the old thinking. So yeah, this graph here was what we all learned, what we learned in school as to why we should do many treatments, and we're rethinking. So this is the rationale as to why. You know, I just wanted to explain why we do it. And this is probably true for a lot of cancers, but we're starting to learn that it may not be as true as we thought for prostate cancers. And so that's why we're thinking that maybe the smaller treatments, bigger treatments might be good. The other thing is our technology's gotten better too. Right? These are all based on radiation treatments that were big, you know, where we hit where the radiation fields were big and we didn't have this fancy technology, so we hit a lot of normal tissue with our beams, whereas nowadays we don't. And so these curves probably don't apply quite the way they did before to what we do today. But thank you.
Any more questions?
Thanks for having me.